When it comes to issues of undocumented migrants and healthcare in South Africa's laws and the policies clash, and these leaves medical staff sometimes confused. Good evening, I'm Aldrin Simpier and this is Unfiltered. The South African healthcare system struggles to provide sufficient medical care to any person regardless of their nationality. What does the law say about undocumented migrants accessing healthcare in South Africa? Tonight we want to ask you as well, who should foot the medical bills of foreign nationals? Have your say on Twitter at Unfiltered SABC, that's our handle. And on Facebook, search for Unfiltered SABC. Tonight, I'm joined in studio by Lerato Mtundi, who is the General Secretary of the Young Nurses Indaba Trade Union via Zoom. We are joined by Ntoveteni Ligege, who is the Chief Executive Officer of Messina Hospital, that is in Limpopo, and Hlengwe Machacha, who is an attorney at the Lawyers for Human Rights, Refugee and Migrants Program. They're all joining us this evening. Remember that you can also be part of the conversation going via social media. Dr. Ligege, let me start off the conversation with you as a person who's heading up a healthcare institution, of course, being in the public sector as well. What's your experience been like?
Yeah, let me start by putting my disclaimer before my viewers. Once more, good evening. I'm Mr. Ligege. I'm not Dr. Ligege yet. But then, be it as it may, we are actually running the confused system simply because of the impact on the influx of the illegal mobility, simply because of an undocumented or illegal national patient who are actually coming to our country unlawfully so. So we find ourselves being strained or pressured in terms of our systems, healthcare systems. You know very well that our primary objective is to make it a point that we try by all means to strengthen our healthcare system efficiency. So if we've got some confounders on the way, which are simply because driven by the influxes of undocumented foreign nationals, it actually compromises us heavily and puts strains on our systems, which of course we find ourselves running a confused system. And the only people who could actually bail us out, it is nobody but that ourselves. That is why you might have seen one of our own MEC going all out, trying to showcase the frustrations on social media or on the print media, simply because enough is enough, and it's long that we've been sitting on a ticking bomb. And that ticking bomb has now exploded. And we are about to run an imploding, totally collapsed services in South Africa. Remember, in USA, if ever you remember very well, they've actually adopted a slogan called Black Lives Matters. In South Africa, we are simply adopting the very same slogan, which says South African Health Matters. So there's nobody who could actually come into picture. And the solution will never come from UK, let alone USA. It has to come from within, wherein we must make it a point that we tighten our ball and nuts in terms of our healthcare system. And we close that tap, which actually made us to find ourselves mopping waters on a daily basis. So if we close the tap, is then that we'll actually be able to resuscitate and save the sinking ship of the South African healthcare system by start doing the right thing. Because it's long that we've been suffocating, not saying anything. And we thank our MEC, who actually make it a point that she spilled the bean, even though the interpretation on the ground from the public opinion, some are misinterpreting it. Thank you very much.
Yeah. What would you say is the split when it comes to your patients, in whether South African or being an undocumented foreign national, or even a foreign national for that matter who is documented? What sort of split are you looking at Messina Hospital?
At Messina Hospital, everything since the outcry of the influx, remember it has not started now. It has never started before COVID. We found ourselves being the hub of the running the confusing system, be either through the human resource point of view, from the budget point of view. So we are running ourselves with a limited budget simply because whatever we do, remember, we are a gateway to Africa. We are serving inside the country. It is not only Zimbabwe, some of the countries as well. But the major hub in terms of frustrating our systems is our neighboring countries, which of course,
but what's the split between if you look at 100% patients, how many of those 100% patients are foreign nationals?
On record, we are talking of 60, a ratio of 60 to 40. is 60 to 65 of non-South Africans against 30 to 40% of South Africans.
Yeah. And I'm asking this question, Mr. Lekeke, because the minister had told Parliament that hospitals don't necessarily keep stats of foreign nationals that they serve. So where do you find those stats from?
We have got a system which runs on daily basis, and which, of course, if ever we could just make a print out now, it actually shows all the variables and the parameters which will actually convince everybody on the ground. So whatever I'm saying to you right now, it is there in black and white, which of course it could actually serve as my MOV on my means of verifications. If somebody comes in and says no, to validate and verify whatever you have been saying, can you showcase us that statistics? We'll be able to print that and showcase them.
Okay, Lerato, just quickly before we go to the ad break, for nurses and their experiences in some of these hospitals, what have they been telling you?
Aldrin, we went on the ground, not just on our social media pages, but generally engaging with our members. And the members said, look, the reality is that we are not coping even with just South Africans. So imagine an added burden because of porous borders. We are really understanding what the laws and the legislation is saying, but we are not about to take that lesson right now. What we are feeling is that the country and the healthcare system is no longer even in ICU, is literally in mortuary. And the sooner the government does something with our porous borders, we are going to be having not a collapsed system, but a system that is in a state of disarray.
Speak to us quickly about those experiences of working in hospitals where you have what you call this added burden.
Look, our hospital beds, and you'd understand, they are bound by the pledge. Doctors are bound by the oath. Mm-hmm. And even though you know you are not able to service South Africans, or you are not able to service people because of you can't discriminate because of nationality, the creed, the race, the culture, you have to take everyone, especially looking at the triage model, that you have to take those who are more critical. It is the truth. The latter speaker has said it a mouthful. We are experiencing, or the experience of nurses is that we have more foreign nationals in our clinics, in our hospitals, and unfortunately, they feel if something is not done, they will have to take it up to the streets, like we saw in Steve Biko, those actions, protest actions starting to actually say, we are no longer able to take you in.
And what we've seen earlier on today as well in Kalafong, that is in Pretoria as well, where you had some people who call themselves Operation Tutula, demanding that foreign nationals who are in that hospital be taken out, and also blocking certain patients from accessing the hospital facility. And the Department of Health in Gauteng has said that they have sought an urgent court interdict to stop the protesters from the action that they have been carrying out. However, though, this morning again, they still continued with that. But we'll continue with the conversation just after the break. Be part of the conversation as well by going on to our social media pages. And welcome back to Unfiltered, as we have a conversation focusing on what's happening in the healthcare sector, but also the impact that it's having on the healthcare system and the system being under pressure. And also the question that we're asking you this evening is, who should be footing that bill? Who do you think should be footing that bill? Lerato, I just quickly wanted to ask you about the split in terms of the burden again that you speak of, but the ratio, nurse per patient, what are we looking at?
Normally, Aldrin, we'd want to be seeing 1:5 in our medical surgical wards, our general wards, but the current realistic picture is 1:30. In a labor ward where a nurse is supposed to be seeing 1:1, a nurse is literally delivering 1:10 babies. So obviously that is a state of disaster. In a clinic where a nurse is supposed to see at least 30 patients per day, they're seeing more than 200.
When would you say that thing became an added burden?
I think it came with democracy. And I think it became clearer when our government and their rules became extremely laxed. And also the fact that the healthcare system access became a free-for-all, unfortunately.
Okay, let's quickly go to Hlengiwe Machacha, who is an attorney at the Lawyers for Human Rights, Refugee and Migrants Program. Hlengiwe, good evening, and thank you so much for making time for us. So earlier on, Lerato did speak about the laws and also that it is a constitutional obligation to serve people who are in need of medical attention. Just tell us quickly, what does the law say about that?
Well, beginning with the Constitution, Section 27 is very clear in that everyone is entitled to access to health care. So everybody within the borders of South Africa, regardless of their documentation status, is entitled to access to health care. And then looking at the National Health Act, then it provides for different levels of care, and it also provides for free basic health care. Specifically, I will go to the issue of pregnant and lactating women. They have free access to basic health care, and children under the age of 6. So regardless of their documentation status, everybody who is in that category is entitled to free access to basic health care. Yeah. And obviously, emergency health care is free for everyone, and documentation status shouldn't come into the question under no circumstances.
So in the case of the patient that was being addressed by the MEC last week, does basic health care also cover elective procedures or surgeries?
Not necessarily. I think that's where the complication lies. Then with each level of care, one would have to be subjected to a means test. So the National Health Act is very clear in that whichever public health facility you're accessing, you are entitled to actually go through a means test to assess what you can afford, and then you will be billed accordingly. But you will be given access to that health care first, and then you will be billed after you've received treatment. So that patient would obviously have been screened and assessed in terms of what they can afford, and they should have been briefed prior to the procedure having taken place.
And does the screening also include looking into the person's nationality as well as where they are domiciled?
Well, our understanding, or my understanding of the patient charter, for example, is that if you're accessing healthcare, in order for the facility to open a file, for example, and figure out which service or which procedure you're undergoing, they have to check your documentation status just for the purpose of identifying you. Your nationality actually doesn't matter. So your document status is just to identify you, and also, well, beyond that, they start to assess your income level and where you fall into the different categories of income and how you can access that care.
Okay. Mr. Ligege, when it comes to the issue relating to elective procedures, for instance, what has your experience been like? And I remember when I was in Zimbabwe, and I've spoken to some of the Zimbabweans after the removal of Robert Mugabe, and one thing that they said that they're looking forward to is a health system that is improved. However, though, they do speak about relying heavily on the South African hospitals. So what's your experience when it comes to that, when it comes to especially elective procedures?
Yeah, our experience is that we seem to be inheriting everything. Either is micro or that's macro from that other side of the country, simply because they must be able to distinguish between what is actually emergency and what is not emergency.
Yeah.
Irrespective of elective procedures, you cannot come to us as part of the health professionals post-op of where so you know that the procedure is very much expensive. It demands a lot of time from the workforce's point of view. It demands a lot of time from the financial risk protection point of view. So we are simply saying, whatever we do, as long as it is communicated well in advance, they should know that there is nothing for mahal or there's nothing for free. And we are simply saying to them, as South African policies, our measurable goal or performance goal is to make it a point that customers are satisfied.
Yeah.
It's to make it a point that we achieve positive health outcomes. And part of achieving positive health outcomes is when we see to it that we must actually embark on a thorough risk management, which is basically what our principal was trying to do when she was doing rounds Post-op, we must make it a point that we do risk management. Part of risk management, we then mitigate that. So basically, this is what we're doing in South Africa.
Yeah, Mr. Ligeke, when a means test has been conducted, and the decision by the hospital is that this particular person can afford, and therefore this person will be charged, what's your experience when it comes to patients who actually owe the hospital? And now specifically speaking about foreign nationals who are in the country and using your facilities, do they pay?
To be honest with you, they don't pay. There is an element of dishonesty. Simply because the reason why I'm saying that, in terms of all my payables, I cannot guarantee the fact that I'll actually recoup or retain 100%. I'm struggling on a daily basis, and I'm running a very frustrating system. I don't have a problem with local. I'm not trying to be xenophobic here. But what I'm trying to showcase the fact that on a daily basis, I'm being confronted with people who are actually running away from their responsibilities. And then for me to be able to trace them through their landmarks, it is not possible. Yeah. Because today they are Thomas, tomorrow they are Daniel. Even though they are in South Africa, they are actually moving from point A to B. And for us to be able to go after them, it is not simple, simply because majority of them, they are undocumented and they are in South Africa unlawfully so.
Okay, just quickly, Hlengiwe, on this question around the cost that's borne by the hospital once some of these operations are undertaken, what does the law then say? Should a patient not be able to pay, or should a patient refuse to pay?
Well, it's difficult for me to answer that question. I think it goes into the fiscus of the Department of Health and how they are able to manage those patients who are unable to pay. That is, the prerogative of that particular hospital and how they are run, and it must be well communicated to its users. However, the challenge that we mostly experience, with health users who approach our organization for assistance and intervention, is that there is a blatant institutional xenophobia at the point of access, such that they don't even get the proper information in terms of how the finances of that particular hospital are managed and which procedures cost how much money and how one can even manage that debt. There's always an assumption that if you're a foreign national, you're not going to pay, and then you're automatically placed on the highest scale as if you are in a private hospital, or you're assumed to be someone who can probably afford medical aid. So there isn't that proper dissemination of information when people are trying to access healthcare. And the lived experiences show that there's that institutionalized xenophobia of turning people away even before they can ask questions and get clarity on how does this institution work, how does this hospital work, and which procedures cost what amount of money, etc.
Okay, when we come back, we'll have a conversation around what proposals do we think would actually get the system to be much better. And some have even suggested that the bill should be sent to the patient's country of origin, and the government there should then foot that bill. Is this something viable? Do you think this is something that our country should be exploring? That conversation when we come back. And we're getting some closing remarks and also suggestions on how do we get this healthcare system back online. Lerato, you were saying earlier on that it is as good as dead.
Absolutely. I think when you work in Baragwanath and you ask anyone, they'll tell you that they welcome buses that arrive at the taxi rank. And those who are in the nearby clinics will tell you that the patients from other countries begin to shop. They'll be here for 5 days and they'll be in various clinics to collect medication for even their family members. We do not have a system that tracks which patients we are helping locally and even foreigners. We do not have processes.
But didn't we say we're introducing an e-filing system?
Oh, which one? We still don't have anything. This state of disarray is definitely serving someone, and unfortunately is not serving the South Africans that are outraged currently by this current system. The health department needs to be given a proper spotlight on this one. There are no processes, there are no systems, let alone talking about the borders, which is a story for another day.
Do you think that patients, the countries of origin, should cover their medical bills?
There is absolutely no necessity for that. Our country must clamp down and ensure that our porous borders are strictly managed, not the current state that we are in. Secondly, access to health care in terms from legislation flowing, it's time that those are reviewed. Our members are punished daily for saying no, or we cannot assist a patient. As unionists, we represent members simply for refusing or being unable to give patients from different countries a treatment or any form of care. And unfortunately, people lose their jobs in this country because unfortunately, there is no resources, material resources, human resources alike.
Mr. Ligeke, some proposals perhaps from your experience based on working at Messina Hospital?
Yes, yes. As much as we have declared that as Messina Hospital, which is part of Limpopo, we have reached a crossroad, and that crossroad compels us to apply some bit of paradigm shifts. And paradigm shift is wherein we must make it a point that we engage the embassy of the country concerned or the country of origin. They must make it a point that whoever is owing the institution, the facility, they must be entitled or responsible to foot the bill. The unfortunate part with me, say, is that the nearest embassy of either Zimbabwe or Zambia or Mozambique, they are all in Pretoria. So my wish and my frustrations or my flood of frustration, which I escalate to them, is that the only way for us to win is when they decentralize the decision space. Decentralizing the decision space makes the point that they either have a mobile embassy office wherein we'll continuously escalate our flight in terms of the invoices to the nearby embassy, which is mobile, if it was doable, or provincially, or if district. But for us to say, as part of the NHI funds, and the nearest embassy of those countries, they are very far. Look at Messina. I'm almost 400, if not 550 away, singing, to reach that embassy. So we are saying they must come on board and find a way and means, either through SADC, wherein they generate policies, or what could be the best practice in terms in relation to save this sinking ship of healthcare practices inefficiency, simply because for now it has totally imploded.
Okay.
We are actually saving an imploding healthcare system.
Okay, and thank you very much, Aja. Just quickly, some suggestions from your end as well?
Yes, I do support some of what my colleagues are saying in that there's a need for further engagement. The most pressing need is to actually get reliable disaggregated data on the movement of people from different countries and to actually appreciate their health needs as they move between South Africa and their countries of origin, and engage those governments as well and explain, try to sensitize them to the situation of what is going on in South Africa at the moment. So there is a need for further engagement with all stakeholders, including the health users themselves, not excluding the foreigners as well as the citizens. There's a desperate need to actually get the information correct and get the data right, so that there isn't perpetuation of stereotypes and the wrong information, which harms the most vulnerable at the end of the day.
Thank you so much for your time. That is Hlengwe Majaja, Lerato Mthunzi, as well as Ntovedzeni Ligeke, who are joining us this evening. And thank you so much for listening to us and watching us this evening on S3 Unfiltered with me, Aldrin Simpier. We've come to the end of the show. Do enjoy the rest of your evening. Totsiens, see you again next week, Monday. Same place, same time, right here on S3.